Okay. Good afternoon, everyone. On behalf of the Thai Society of Gynecologic Endoscopists and also the Thai German Multidisciplinary Endoscopic Training Center, I would like to welcome everyone to join our monthly webinar. Today we will have a session that's very interesting about the HIFU, game changer of the uterine fibroid and also adenomyosis management. So as we know that uterine fibroid and adenomyosis are benign female disease that frequently affect about 40 to 50 years old women presenting with a very extent of clinical symptoms, such as an increased amount of the heavy menstrual bleeding, compressive symptom, and also gradually aggravate dysmenorrhea, which may lead to sterility and also recurrent pregnancy loss. The common treatment include medical and also surgical approach. Minimally invasive surgical technique as a laparoscopic myomectomy and also adenomyomectomy is quite common and might became a gold standard in nowadays. However, a novel non-invasive treatment for this common gynecological pathology as HIFU has been introduced into China since the 1990s with a good clinical efficacy by many papers published. So today we have a good opportunity to talk and also deeply discuss on this novel non-invasive treatment with our two invited speakers. So the first one is Dr. Olalik Muksikawong. Okay, สวัสดี Professor Olalik. สวัสดี is a mean good afternoon or good day in Thai.
สวัสดีครับอาจารย์ครับ
ครับ สวัสดีครับ So Olalik is a Thai obstetrician and gynecologist. He is currently working at Chapaya Phaiphupet Hospital in Prachinburi, Thailand. Olalik has graduated from Faculty of Medicine, Khon University in Thailand and attended professional classes of reproductive medicine at Lama Thipadi Hospital, Maidan University. He also attended a fellowship laparoscopic training in Kurashiki Medical Center, Japan, and also reproductive surgery training course in Belgium. Moreover, he received a master's degree in the biotechnology of human assisted reproduction and also embryology from University of Valencia in Spain. Regarding his extraordinary achievements, he has been appointed in honorary position like a chair elected of complementary and integrative medicine special interesting group of American Society of Reproductive Medicine and also a social media team leader of American Association of Gynecologic Laparoscopists and also honorarium advisor of Health Tech Startup Society in Thailand. So let me introduce the second one. The second speaker in today is Dr. Sevara. I also call him Seva. Sevaraja Supermaniam. Seva, he is a consultant obstetrician and gynecologist and also a specialist in reproductive medicine at the Makota Medical Center in Malacca. He also head of IVF center at this hospital. He is a fellow of the Royal College of Obstetricians and Gynecologists. He obtained his Master of Reproductive Medicine from University of Western Sydney in 2003. He is a past of President of Obstetricians and Gynecological Society of Malaysia, a past President of APEC, and also a past board member of the ISGE. Currently, he is board member of APGET and also reviewer of Journal of the Asia Pacific Society Association of Gynecological Endoscopy. Selva, he is a dedicated laparoscopic surgeon, as we know. He has performed about 8,000 cases so far. He also ran a fellowship in minimally invasive surgery and infertility in Makota Medical Center, the first of its kind in a private hospital in Malaysia. So far, he has trained 9 gynecologists. He published his first book entitled Laparoscopic Surgery in Gynecology and Common Disease in Women, a book to educate the public and doctors on the benefit of laparoscopic surgery in women. He has also numerous publications in an international journal, mostly on the topic of minimal invasive surgery and fertility. He also runs a blog and a podcast entitled Surviving Private Practice in Malaysia. He just started the first ultrasound-based HIFU center at Makota Medical Center and will be provide non-invasive surgery for fibroid and also adenomyosis. I think today is a very good opportunity for us to have our two invited speaker to talk about the HIFU and also maybe overview about the adenomyosis and also myoma uteri. So the first one is Olalik. We will talk about the overview about the myoma uteri and also HIFU, and about 30 minutes, and then we will follow with Dr. Selva to talk about the adenomyosis and also HIFU and also share his experience about the HIFU. I think today we will get a more experience. So finally, 30 minutes, we will come to join together to talk and also answer the question and some discussion together. Okay, I think it's the time that start. Okay, Dr. Olarik, maybe you start first.
ครับสวัสดีครับ so can you hear me
Sure, good, very good.
okay thank you Professor Ampan for a very kind introduction and good afternoon Professor Selva. So for other doctor, if you want to remember Dr. Selva name, I also remember him Dr. Professor Selva Superman. Okay, it's very easy to remember his name. Okay, so by the way, today I will talk about the HIFU. It is the game changer of uterine fibroid management. Okay, and for today's topic, I don't have any conflict of interest. Okay, so what is my outline? I would like to talk about the HIFU is a game changer for who? I think the first one is for the patient. The second one is for the provider or the physician. And the last one is for the public. Okay, so why the HIFU is a game changer for the patient? Okay, so as Professor Ampan said, uterine fibroid is a very common disease in the women. There is the data. This is published in USA, in Washington, D.C. It is a survey and check about the history of the ultrasound of the patient, white and black patient. So we know that it's almost 80% of the black patient have uterine fibroid. So this screen this slide is show the estimate age-specific cumulative incidence of a uterine fibroid in the Black woman and white woman, the age at 50 to 49 years old. You can see that it's almost 80% of the African American has a uterine fibroid, and it's about 60% of white women have the uterine fibroid. But just only 50% of the patient have the clinical relevant, such as the abnormal uterine bleeding, bulky symptom, or the reproductive problem. And of course, in the why women have less clinical relevant, I think it depends on the incidence of the fibroid. If you have the lower incidence of the fibroid, you will have the less symptom. It's very relevant. So I would like to say that the uterine fibroid is one disease, but there's many symptoms. This is my patient who have at least to fibroid anterior and posterior wall of the uterus. So this is one of the most common symptoms is abnormal uterine bleeding. We know that thyroid uterine fibroid can cause like heavy menstrual bleeding, can cause the intermenstrual bleeding, spotting. So this is very, very common. The second one is a bulky symptom. Sometimes the fibroid is very big, like 20 pregnant women, 24 pregnant women. And of course, I know somebody have experience like the very big fibroid is around 30 centimeters that show on the Thai newspaper. And of course, the patient have the symptom like constipation, frequent urinary retention. Okay, and of course, the uterine fibroid can cause the pain, such as dysmenorrhea or chronic pelvic pain, and some patients have a radiate pain to the leg, maybe a left or right, or some patients have the low back pain. And today I would like to focus about reproductive dysfunction, such as recurrent pregnancy loss, miscarriage, or there is a problem about obstetric, such as the preterm labor, increase the number of cesarean section. And we know that in Thailand, we have the high percentage of cesarean delivery. In Thailand, it's about 44 to 50% of the C-section. And WHO said the C-section is over 15% is not necessary. So that is another project that I involved to decrease the unnecessary cesarean delivery. Okay, this is the publication of the Ian Fraser. He is like a godfather of the heavy menstrual bleeding. And as we know that Professor Petra J, he is the president of the CUT. The data is show the prevalence of heavy menstrual bleeding in Europe. It's about 1/4 of the women have the problem about the heavy menstrual bleeding. And this is the data in Turkey, the incidence of the heavy menstrual bleeding and can decrease the quality of life is about 40% of the women. So this is my question. Actually, I will speak in Thai, but Professor Ampan said there is some foreigner audience, so I have to speak in English. But I would like to ask the audience that, so what do you think about your period? Is it too much? Do you have heavy menstrual bleeding or not? So please reply on the chat. The first one is normal. The second one is heavy menstrual bleeding. Or the third one is that you don't ever think about your period. So I cannot see the answer on the chat. Dr. Ampan, are there any audience reply on the chat? Nope. But why I asked for this question, because there is the publication in China, the prevalence and knowledge of the heavy menstrual bleeding among the outpatient. The questionnaire is done by the WeChat. WeChat is like a chat application, is very famous in China. There is more than more than 1,000 patients. Okay, it's a 1,152 patients fill out this survey. Okay, that is about 78% of the patients have the heavy menstrual bleeding. So the question is how they calculate what is the heavy menstrual bleeding. They use the PBAC. What is the PBAC? PBAC is a pictorial blood loss assessment chart. If you use the pad, you have to check is your periods is light, moderate, or complete of the pad. And this is the scoring. If you use the tampon, there is a scoring, or even you don't use the pad or any tampon, if there is some blood clot, you can check it. You can calculate until the last day of your menstruation. So this is very interesting publication. That is 68 patients, they answer their menstrual is normal, but actually in the real life, the PBAC is more than 100 score. If you have the heavy menstrual bleeding, the PBAC you are already more than 100 score. That means 68% of the patients, they don't know that they already have the heavy menstrual bleeding. So I don't have the data in Thailand, but I think this maybe Dr. Pattaya, I think she's in this room too. So she will do this research in Thai patient, because this is like a kind of the increase the awareness for the women. If you have the problem, you have to come to see the doctor very early. So most of the patients, they say they have the heavy menstrual bleeding when the PBAC is more than 300. So this is the big problem. So what is the impact of the anemia when you have heavy menstrual bleeding? Of course, it impacts the quality of life. It increases the emergency admission, increase the blood transfusion, and increase the healthcare cost. And this is another important publication they do in 5 countries in Europe. It's more than 30,000 women, that 80% of the women have the problem when they have the period. They cannot go to the school. They have to like a sick leave for the workplace. So after this publication, there's a lot of company have the new policy for the sick leave for the women who have the menstruation. I think if we are the policy maker, we have to think about this. So back to our clinical aspect, we know that when women have the abnormal uterine bleeding, we have to approach by the palm coil, polyps, adenomyosis, leiomyoma, malignancy, coagulopathy, ovarian dysfunction, endometrial eye heterogeny. And this is the last one, not otherwise classified. Today, I will focus on the leiomyoma. We know that in many years ago, we categorized the leiomyoma only in 3 categories: submucous myoma, intramural myoma, and subserous myoma. But we go have the more specific type of the myoma. They categorize to the 8 type of the myoma, type 0 to type 8. And by the way, we know that one women, they don't have the single myoma. Some patients have the multiple myoma, and some myoma is a hybrid type. So this is very complex disease. So I would like to focus on the second one is uterine fibroid management. So what is the management for the patient? We know that the history taking, the physical examination and investigation, every step is very, very important. In my opinion, I think the history taking is one of the most important part. Same as Professor Ampan always said that you have to ask the patient. For example, if the patient have the pain, you have to ask that which side of your pelvis have the pain, because sometimes we can ultrasound see the fibroid on the right side, but the patient have the pain on the left side. We have to very focus on the clinical, not only on the investigation. Okay, this is the type of the uterine fibroid symptom health related questionnaire. Uh, I would like to suggest everybody to use this checkbox, used for in history taking and used for the follow up, because after the treatment you can do the scoring for the patient. You can search on the internet. I'm not sure there is a translate in Thai. If anybody want to translate in Thai, please let me know. I will use it for my patient too. Okay, and this is the second one from the fecal system. We know that this is the palm coil system. I would like to tell you that for the women who have the abnormal uterine bleeding, maybe they don't have only one disease. Some patients have the fibroid and they have the abnormal ovulatory function. Some patients have a polyp with adenomyosis. So this is a checkbox again. You have to rule out every disease that can cause the abnormal uterine bleeding. If you check and you found it, check yes. If you check it and you do not find it, check no. And if any cause you have not checked yet, you check question. You have to check all of the disease, the possible disease, possible cause. Okay, and this is the investigation. On the left side is 2D ultrasound, and on the right side is a 4D ultrasound. It's slightly bigger. I would like to recommend of you try to use the 4D transvaginal ultrasound. It's very useful. Okay, we know that sometimes we cannot see the type 0 or type 1 by the 2D ultrasound. You have to do the SIS, satellite infusion sonography, to diagnose the type 1 or type 0 of uterine fibroid. So this is the type 1 about 2 centimeters. Okay, and this is the MRI. We know that in many countries, in Japan, in Europe, many countries, they use the MRI for diagnose the uterine fibroid. Maybe we can share with Dr. Warade. He is in this room too. He is training in France. He said that all of the case, they do the MRI for the diagnose uterine fibroid. In my opinion, for the patient who want to do the preservative surgery, I would like to recommend to do the MRI, because we can do the uterine mapping. We can use it for the counseling the patient, which fibroid we will take out, fibroid we cannot take out, and we can plan the incision on the uterus. Because of one incision, we can take like 2 or 3 fibroid in one incision. That can disease. This can decrease the adhesion post the surgery. So what is the treatment? We know that we have the medical treatment and we have the surgical treatment. I think I have only 5 minutes left. This is all over the medical treatment in the world we use. And this is the surgical and intervention in the world we use. And today I would like to focus on the ultrasound guide and we have a lot of time to discuss with the Professor Silva what is the HIFU ultrasound guide. Okay, this is the diagram of the medical management of the abnormal uterine bleeding P, A, and L. Okay, for the type 1, we know that we can do the myomectomy by hysteroscope, laparoscope, or laparotomy. How about the type? How about the women who want to have the future fertility? We know that the myomectomy by the laparoscope or laparotomy can cause the uterine scar that can have the incident of a uterine rupture. So what is the most proper intervention for the patient who want to have the baby in the future? Is it UAE? Is it HIFU? Or is it a radio frequency? We know that the data of the UAE uterine artery embolization, we do not suggest that for the patient who want to have the baby in the future, because when you have the when you do the embolization, it's not decrease just solely the fibroid, but it decrease the blood flow to the endometrial cavity. So it can decrease the implantation rate when you do the IVF. So how about the HIFU? And this is the conclusion of the treatment of abnormal uterine bleeding, medical and surgical. Okay. This is I think this one is the most important slide of my talk. This is a care plan. This is a reproductive life care plan for uterine fibroid. When women have the history of a uterine fibroid, I mean the family history, we have to prepare since they have the menarche. So what is the plan? We know that we want to do like a plan A. Everything is very easy. Okay, plan B is a little bit difficult, but in the real life, as we are the doctor, this is a plan C. Is like many complex situation. Some patients just only have the fibroid without any clinical issue, but some patients they have the abnormal bleeding, they have the bulky symptom, they have the pain. So we have to plan it until there's a menopause. So what is the HIFU? Oops. Okay, so what is the evolution of the surgery? Okay, we start at conventional surgery. This is my picture when I was in the second year of the resident in Udon Thani Hospital. It's elective. It's the best time of my life. The first surgery by myself. Okay, and then we move to a laparoscopic procedure. And now this is a HIFU era. The doctor don't need to stand for a long time. Just sit on in front of the computer and just click. Oops. Okay. Oops. So what is the HIFU? This is the principle of a HIFU. Is that we have the transducer. They convert the electric energy into acoustic energy, and it destroy the tissue because they have focus points. The focus point is the temperature is rising over 65 degrees and reversible coagulative necrosis of the tissue. Oh, I have no idea why my slide is too fast. Okay, and this is the focus point. The focus point is around 1 centimeter. You can see the transducer use the acoustic power pass the skin to the tissue. You use the ultrasound guide. We have the two types of the guidance. Professor Silva will talk about it again. Okay, so what is the HIFU operation room? It's just only the small room 5 × 5 made, just only one machine, computer, anesthetic machine. So this is the hospital that I have the chance to attend the operation. This is the hospital in Barcelona. It's about 300 hospital. It's far from the downtown, about 50 minutes by car. You can see just only 4 staff in that room. One is the doctor. He is the gynecologist. One is anesthesiologist. One nurse, and one staff who like circulating staff. Just only for staff that you need in this operating room. Okay, and the patient is lie down on the machine. They use anesthetic, the light anesthetic. You can wake the patient up anytime you want. And when the HIFU beam attack the tissue, you can see the immediate effect post the treatment just only one day. The average annual absorption rate is almost 70%. This is the meta-analysis by Dr. Lu. They conclude that after do the HIFU, the better quality of life, better uterine fibroid symptom, and the time to return to work is shorter than laparoscope. The duration of hospital stay is very short. In Spain, they do like 1 day surgery, just only an OPD case, just come to hospital in the morning, and in the afternoon you can go back to your house. Okay, and this is I would like to focus is a pregnancy outcome after the ultrasound guide HIFU. He is a publisher, Professor Jordi Rodriguez. Actually, he is the oncologist who do the laparoscope too. He do the HIFU 2 days a week. And he has experience more than 10 years. This is the publication in 2019. Is a retrospective study. They collect the data since 2008 to 2018, analyze the pregnancy outcome of the patient. Okay, so there is a 70 pregnancy in 55 patients, and 58 case is a natural conception, and 13 was by the IVF. So the median time of the conception is about 1 year. Why we choose the HIFU? Because we know that when we do the operation, there is a lot of the complication. You can buy this book online. The fibroid uterus, the surgical challenge in a minimal access surgery. Is about $200, and I have one chapter. It is about the breach of the endometrial cavity during the myomectomy, and it implication for the subsequent fertility. Because we know that when we do the myomectomy, is about 50% of the operation have the complication of the endometrial cavity. So we have very careful if patient want to have the baby in the future. Okay, by the way, back to that publication by Dr. Jordi. This is the image of the 30-year-old women have the vaginal delivery after doing the HIFU. You can see this is a big one as the posterior part of the uterus, and after doing the HIFU, you can see on the picture D. It's almost 80% of the volume of the fibroid already decreased, and the patient have the normal natural conception. And this is another case. You can see in this MRI, it is very difficult to do the operation in this type of the fibroid. How we remove this myoma? In my opinion, it's not possible. My on my hand, maybe if you have the experience, you can do the surgery. 3 years ago, we have the medication, the UPA that can decrease the volume, but now it's already withdrawn on the market because there is the liver damage. So what is, I will try to treat the patient for now. GNRS agonist. In my opinion, maybe some patient is not very effective. So what is the option? So I think I'm running out of time. I will stop my talk. Oh, okay. This is another one I would like to talk is a game changer of the physician. There's the data of the prevalence of the work-related musculoskeletal disorder of the surgeon. This is a meta-analysis. There's degenerative cervical spine, rotator cuff, lumbar spine, carpal tunnel syndrome. And if we focus on the gynae surgeon, is this the same outcome? There is a lot of the pain on the back pain, neck pain, shoulder pain, least if you do the operation for long hours, you have more symptoms. And this is another publication for the laparoscopist, Dr. Ampan, associated with the increased risk of vertebral prolapse. It's about 20% of the staff who do the laparoscope have this symptom, and they have to do the treatment, definitive treatment. By the way, okay, if you can find the chair, you can sit on the chair. This is the picture in Shanghai. I attend. She is Professor Liu. In this hospital, there is 32 operating room. There is more than 60 laparoscopic cases per day, and every operation room is a 3D machine. So I would like to stop my talk for now. So please, Professor Silva.
Okay, Dr. Oralik, very nice talk. And okay, I think the game changer is quite interesting word. And I think Dr. Silva might be one of the solution because Silva does a lot of laparoscopic surgery in myoma and also adenomyosis. And now I think he changed. I'm not sure absolute change or not. to be to do only HIFU. I think it's got some condition like it's a proper for the HIFU and also the proper for the laparoscopic surgery. So Silva, please.
Thank you, Ampan. Have you? Can you see the screen? My screen?
Sure.
Yes.
Good.
So I can start. Okay. First of all, I'd like to thank the Thai Society for inviting me to give this lecture. So my topic actually will be mostly on adenomyosis, but I realized that maybe I will touch a little bit on fibroid as well. Now this is my disclosure. I run this HIFU center at Makuta Medical Center, and we have been doing it for about 8 months now. Now, let me give you one example. This lady is a 39-year-old lady. She's married for 9 years with no children. She has adenomyosis with severe period pain and heavy menses. She has been admitted for blood transfusion many times because of severe bleeding. Now, she saw me in February 2019. And this was what we found on ultrasound. It's a large adenomyotic nodule, 6.8 times 6.1 centimeters. So I discussed with her, I said, what are options? Options are either doing hysterectomy or HIFU. I mean, adenomyomectomy is another choice, but we thought it would not be suitable for her. So she said she will wait for HIFU. But because of the pandemic, everything was delayed. And so ultimately she gave up and she underwent a laparoscopic hysterectomy. This is a laparoscopic hysterectomy. I just put it up just to show you all that I also do laparoscopic hysterectomy. So this is a fairly large uterus, up to almost 16 to 18 week size. And I think the TLH, everybody does TLH, but for adenomyosis, it can be fairly difficult. So this is the adenomyosis. So here I'm just suturing the uterine artery on the right side. And then this is suturing the uterine artery on the left side. And so the technique is, I think, standard. It is now, everyone does this surgery. So here I'm cutting the vagina. Now here I'm using a harmonics to detach the uterus. And because the uterus was so large, it's very difficult for me to morcellate from the vagina, because narrow vagina. So I use a knife to actually cut this uterus. So here I've already detached the uterus. And then I use a knife to cut it because it makes me easier for me to remove it from the vagina. So this, as you can see, this is a very large adenomyosis. And it has to be cut into many pieces, and then you also have some small fibroids, and then the pieces were then slowly removed from the vagina. And after that, the vaginal wall was then sutured. This is standard. I think all of you all know this, and we all do this surgery. We've been doing this for years. So here I usually like to suture it in an interrupted manner. So that is the whole surgery. And the uterus was, this is how it looked at the end of the surgery. So the uterus was this was the size. It was not that big, 600 plus grams, but that is what happened to this patient. So I bring this up because this is not uncommon. A lot of women with severe pain, severe dysmenorrhea ultimately give up, and then they have a hysterectomy. So how can HIFU help in this patient? That's a whole discussion for this patient. Now, when we look at adenomyosis, there are two ways in which we diagnose adenomyosis. The first is by ultrasound, and the second is by MRI. Now, by ultrasound, we generally distinguish adenomyosis as either diffuse adenomyosis, focal adenomyosis, or adenomyoma. And this is a book, I recommend this book. It's a very nice book written by my friend Felix Wong on adenomyosis. And if you look at ultrasound diagnosis, there are 6 criteria for ultrasound diagnosis of myoma. Many of us never use all 6. The first we always do is one part is thicker than the other. There is a thickening of one section. Usually it's a posterior, but sometimes it can be the anterior. You can have this kind of small cyst. You can have these lakes of adenomyosis, and these are the ones that I will tell you all later, that's very difficult to treat with HIFU. You can have this kind of lines, which are fan-shaped shadowing, and then echogenic subendothelial lines you may be able to see. You can also see this vascularity and also irregular junctional zones like this, or interrupted junctional zones. But most of us will probably see these 3, which is thickening, cyst, and these lakes, maybe some vascularity. So this is ultrasound diagnosis of endometriosis. Now, for MRI is more interesting because there are many categories. We also say it as diffuse, but they categorize adenomyosis as internal adenomyosis, external adenomyosis, and adenomyoma. And this is all the criteria that they have, the MRI classification of adenomyosis. So the first adenomyosis is called internal adenomyosis. That is adenomyosis in the center. Usually it's a thickening of the junctional zone. This A, B, C, D are internal adenomyosis, various form of thickening of the junctional zone. Then you come to diffuse adenomyosis, which is called, this is a diffuse adenomyosis, which is D and E are diffuse adenomyosis. Then you have something called internal, then you get something called adenomyoma, which are actually nodules. It can be seen in the uterus. It could be either in the intramural, subserous, or even in the cavity. And these are the ones that are G, H, and I. We can also see in subserous. And the last one is called external adenomyosis. These are the most difficult ones. They are actually found outside and they infiltrate into the rectum. And you can have anterior one that infiltrates into the bladder. So in adenomyosis by MRI, you've got different classifications. And when we treat adenomyosis, especially even in HIFU, each type of adenomyosis will have different effects and success rate when we do treatment. So when we look at adenomyosis patients, we actually have two groups of patients. The first are the ones who do not want to conceive. Either they have already have enough children or they don't want to have children, but they want to retain their uterus. This is one group. Of course, patients with adenomyosis, we all know that we can actually remove the uterus and they will be well. But these are patients who actually do not want to conceive, but they want to retain the uterus. The second group are the ones that are most difficult, which are those with adenomyosis and they have infertility or they want to conceive. And these are the ones that are big and problematic. And this is the ones that I see because I'm a fertility specialist. And these are the patients that always land up with me and I don't know what to do with them before. So for those who do not want to conceive, we have many methods of treatment. We can use oral contraceptive pills, we can use Dynogest, we can use Depo-Provera, we can use Mirena, we can give intermittent generation injection, or finally we can do hysterectomy. So this option is available. So many of them, I've got many patients who are on Depo-Provera injection for years and they are very well. Some of them do well with Mirena. And Dynogest also, some patients do well, and even continuous oral contraceptive, some people do well with adenomyosis. But those who want to conceive, we have a problem. So we can't give any of the hormonal treatment. So we only have a choice. We only have adenomyomectomy, or we can give generation analog or Dynogest and then see whether the patient can get pregnant on their own, or we can do IVF and do fluid embryo transfer. So these are the patients that will probably benefit a lot from what I'm going to discuss in a little while. So now, what is HIFU? Dr. Olarik has already mentioned a little bit. It means that we are using ultrasound. We use this for ultrasound to focus ultrasound beam and to ablate the adenomyosis. And I'll just show you a video on this that will explain it.
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focus ultrasound, HIFU, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body without causing any damage to the overlying surrounding tissue.
So that's how HIFU works. So I would like to tell you all that there are actually two different types of HIFU. The first is called an MRI-based HIFU, and it is made by Philips and GE. And this is how it looks. It's a tunnel where the patient goes into this, and then the HIFU is done. And the other one is an ultrasound-based HIFU. This is the leader is actually the HIFU company by Chongqing, China. And this is what I am doing now. So I'm going to give some idea of what these two difference is. When I first heard about HIFU, because MRI-based HIFU has been available in Malaysia for more than 15 years, but we know we never really took it. It never became popular because of some of the problems, the technical problems we have in MRI-based HIFU. And I always thought that it was not very good. So that's the reason why when ultrasound-based HIFU was introduced to me, I was very reluctant until I was convinced by my friend, Dr. Lee Kin Wai in Singapore, that it is a very good product and it is very beneficial. And that's why we started this treatment in Malaysia. Now, this is the difference between MRI-based HIFU and ultrasound-based HIFU. You can see that the probes are different. Here you can see this is the ultrasound-based HIFU probe, and this is the MRI-based HIFU probe. The MRI-based HIFU transducer movement is limited by the size of the hole in the gantry of the MRI. Ultrasound-based HIFU movement transducer is not limited. And this ultrasound-based HIFU can actually move 6 centimeters this way, 6 centimeters this way, 6 up, and 6 down. And that is a big advantage. Whereas this one doesn't move. It is just a static HIFU machine. Another difference is that MRI-based HIFU use phased array transducer. So the advantage of this is that the focus can be moved without movement of the transducer. Now, to move a transducer in the ultrasound-based HIFU, you have to move the whole transducer. Whereas here, they are made of 56 small focal points. So there are many focal points, and these focal points can be moved so that you can actually move the beam from one place to another without moving this gantry. So, but the intensity of the concentration of the focus is not good, and so the power of the machine is limited. That's with MRI-based HIFU, as opposed to ultrasound-based HIFU. We're using a single element transducer, so the machine is very powerful. and the focus is very small and intense. So this is one big advantage of ultrasound-based HIFU compared to MRI-based HIFU. So the MRI-based HIFU uses lower power and has a longer sonication time. So each sonication could take 10 to 20 seconds, which is not very suitable for an organ that moves like uterus. So it is not good for a static organ. It may be good for a static organ like your brain. So for this, what you do is you fix the point and then you wait for 10 to 20 seconds for the energy to reach there. Here, it is not like that. We do it second by second. We are doing it live. That is the difference between these two. So for uterus, especially in a patient who is breathing, the uterus moves, and even the focal point moves, the ultrasound-based HIFU is far superior than that of the MRI-based HIFU. So let me go on to the next slide. So therefore, the advantages of an ultrasound-based HIFU is that it is real-time ultrasound imaging when we perform HIFU with ultrasound-based HIFU. The transducer is larger and more powerful, and better transducer movement during the HIFU treatment, also a shorter operating time, and also better success rate. This is most important. You can get a very high percentage of NPV, which is the non-perfusion volume, with the ultrasound-based HIFU as opposed to MRI-based HIFU. This has been proven with many, many studies. Now, let's look at adenomyosis. What are the benefits of HIFU for adenomyosis? And this also applies to fibroid. It is non-invasive. When the shrinkage of adenomyosis occurs, the uterus will become smaller and it will be more amenable for pregnancy, especially for IVF, and also patient to conceive on their own. There's reduction of symptoms such as menorrhagia and dysmenorrhea. The patient can start conceiving early, even after 4 months of treatment. And the patients can even have a normal delivery after the treatment because there's no scar in the uterus. I'll elaborate on this in a little while. But what are the challenges we face when we do HIFU treatment for adenomyosis? In patients who do not want to conceive, we can use extensive ablation can be performed, and this can include even the endometrial cavity. So the success rate of reducing system is higher in these patients. Whereas in patients who want to conceive, the ablation will need to be done more carefully to avoid ablating the endometrium. In this case, the ablation will be limited and the success in reducing symptom will be lesser, as less energy will be given to the adenomyotic areas. So when I talk to my patients, sometimes they are trying for years, 42-year-old, they are trying for years and they have got severe pain, they've got menorrhagia. I ask them, do you want to get pregnant? Because the way in which we do the ablation will be different. They say, I am not interested in pregnancy anymore, then we can do ablation very extensively and treat as much of the disease as possible. But if they say, yes, I still want to get pregnant, then we need to do the ablation in a more careful manner so that it doesn't involve the endometrium and only the certain part of the adenomyosis can be treated. So patients, another problem is patients with prior surgery. There may be intestines adherent to the uterus, and this may be in the path of the HIFU beam. And so such cases, we cannot do HIFU. And many of my patients who see me have already undergone surgery. They would have had a myomectomy before, or adenomyomectomy before, or some kind of surgery before. And we are always looking for intestines, whether it's stuck to the anterior wall of the uterus, especially where the beam is going to go through. And if there is any such, we can't do. So this is an example. This lady had a large, this fibroid case, actually multiple fibroids, and she had previous myomectomy, and you can see the intestine is actually stuck in front here. So in this kind of patients, we can't do it. This is, I did a laparoscopy for her, and you can see all the bowel are adherent to the anterior wall. So these are the patients that we will not be able to do HIFU for these patients. And here, these patients, I did a laparoscopic myomectomy again after releasing all these adhesions. So let me just go through my experience performing HIFU for the last 8 months. I started on the 12th of July 2021, and until yesterday, we have done 163 cases, 82 adenomyosis and 81 fibroids. It's caught up. In fact, at the beginning, I was doing more adenomyosis. Now, fibroids are catching. Actually, fibroids are very nice to do. They are, because the fibroids are actually localized. They are in a capsule. So the energy will be within the capsule. So it's far more easier to do fibroids than adenomyosis. Adenomyosis is far more difficult because they are all over the place. And yes, I told you all earlier, on MRI, there are different types of adenomyosis. There's internal, external, diffuse, adenomyoma, and they all don't react the same way. So adenomyosis, the success rate is far more difficult than fibroids. So this is my HIFU center. It's a small room, not that big a room, and we place the machine in the center here. And this is our console, and I'll be sitting here talking to the patient here. This is our water system and the power system. So it's a small setup in the hospital, in a private hospital, in the 5th floor of this hospital. So next, I'll just go through some questions that people ask about adenomyosis. Now, first question is, does adenomyosis cause infertility? Everybody say yes, it does. And I think almost everybody listening will say that you must be crazy to ask this question. Of course, adenomyosis causes infertility, and this paper says so. Yes, the patients with adenomyosis have significantly high rates of spontaneous abortion, lower rates of implantation, clinical pregnancy and live birth, and poorer obstetrics outcome. But I was surprised to see this paper in ASHRI, which was published quite recently, and in 2021, and it's entitled "The Impact of Adenomyosis on IVF Outcomes: A Prospective Cohort Study." And the researchers came to a conclusion that when they looked at women with and without adenomyosis having IVF, they found no difference in chances of giving birth to a live baby. So it doesn't matter if your patient has got adenomyosis or not, but when I see patients, they are actually, most of them have already undergone IVF and failed the IVF. And that's when they send them to me to see whether I can help shrink the adenomyosis for the patient and then do a second embryo transfer. The next question to ask is, how does adenomyosis cause infertility? There are many reasons. The first obvious reason is that the uterus is very large and there's abnormal anatomical structure. The uterus is, the endometrium is not in the proper way. It is convoluted. That may cause the difficulty in conceiving. Another reason is the thickened junctional zone. When the junctional zone is involved, it causes a lot of uterine peristalsis. And when there's uterine peristalsis is high, then the patient will not have implantation. Adenomyosis is also an inflammatory process. Anything that is inflammatory will know that we know that the pregnancy rates are lower. And also there may be endometrial dysfunction due to some sex hormone synthesis in the endometrium. And lastly, there may be prolactin levels may be higher in adenomyosis. So these are all the reasons why patients with adenomyosis have difficulty in getting pregnant. So what options do we have for a patient of adenomyosis who want to conceive? We can either do IVF and ICSI. Many of them actually go through this process, IVF, ICSI. And after the IVF, ICSI, if the frozen embryo transfer is done and they didn't get pregnant, many of them give GnRH analog or Dynogest for maybe 3-6 months, and then let it shrink down, and then do the frozen embryo transfer or ask them to get pregnant. This is another strategy for patients with adenomyosis. Now, the last resort is actually adenomyomectomy. Adenomyomectomy is a surgery that I don't like to do because always I'm not sure how much I'm cutting and how well have I reconstructed the uterus. And the last is now this high intensity focused ultrasound. So let me look at the difference between adenomyomectomy and HIFU for patients who want to get pregnant. The advantage of adenomyomectomy is that if we remove the adenomyoma, if there is a focal adenomyoma, we can cut it out and it is taken out. In adenomyosis, in HIFU, the advantages, as you know, there's no scar in the uterus will shrink, there's no skin incision, there's no anesthesia, we do it just under sedation. It can be done as a daycare procedure, the patient can go back to work early, and the patient can conceive after 4 to 6 months. Now, and also you can repeat it. If it recurs, you can repeat the HIFU treatment. Now let's look at disadvantage. You know that when we do adenomyomectomy, there's a scar in the uterus. There's a risk of uterine rupture when the patient gets pregnant. This is what I am always worried about. If I do an adenomyomectomy, if the patient gets pregnant, I'll be worried until she delivers whether the uterus is going to give way or not. It's usually a very difficult surgery, and also it can be done. We can do it for focal adenomyosis and adenomyoma, but not for global adenomyosis. You can see you can't do adenomyomectomy for this kind of patients. Maybe for this, and this, you can do adenomyomectomy, but not for a diffuse kind of adenomyosis. And it's also very difficult to repeat it. You can't be doing adenomyomectomy over and over again for a patient. So this disadvantage of HIFU is that not all patients are suitable to undergo HIFU. I will discuss about this in a little while. You may not be able to ablate the lesion. Sometimes the position, the way the patient, the adenomyosis is, we are not able to ablate. And another problem is ablation may be incomplete. You cannot completely do the ablation because of several reasons. It may recur, and if the adenomyosis involves the endometrium, part of the endometrium may be ablated. This has happened. I'll show you this because we try our best not to involve the endometrium, but sometimes you cannot avoid because the adenomyosis has already gone right through and into the endometrium, so it may be inevitably ablated. So the next question is, in this study, they tried to look at adenomyomectomy or HIFU, a comparison of reproductive outcomes of patients with adenomyosis and infertility with high intensity focused ultrasound and laparoscopic excision. And it is done by the department ONG in Changsha China, and they concluded that HIFU shows a safe and effective profile as a therapeutic management option for patients with adenomyosis in comparison with laparoscopic excision. HIFU treatment achieve a better post-operative reproductive outcome. Treatment should be encouraged and implemented in clinical practice. So there is, in this study, they say that there's a role for HIFU for patients with adenomyosis. Next question people ask is, does HIFU affect ovarian function? And this study has clearly shown that they did AMH before and after HIFU for patients with fibroids and adenomyosis, and they found that the AMH level is the same. So the HIFU does not involve ovarian function, because when we are focusing the beam into the uterus, the ovaries are far away from the area where we are focusing in it, and we usually have a margin, at least 15 millimeters margin from the serosa when we do this ablation. Now, another question is, does the HIFU affect endometrium? So again, when we are doing HIFU, we are actually shining a beam into the uterus, sometimes through the endometrium to the posterior wall. If the anterior wall, we don't go through the endometrium, but if it's a posterior wall, we are shining through the endometrium. Will there be any effect to the endometrium? In this study, what they did is they took endometrial sampling from a patient before HIFU, and then they took it after HIFU, and they found that it did not reveal any negative effects of HIFU ablation of uterine fibroids on endometrial receptivity in women with reproductive age. So what are the risks of patients of HIFU for patients with adenomyosis who want to conceive? As I say, I always tell my patients there are three things that I'm worried about. First is bowel injury. Bowel injury is when you're shooting the HIFU, you must not have bowel in the way. And we have got several ways to push the bowel away, especially on what we call as the head side of the uterus. The second is nerve injury. Now we know that when we shoot a HIFU beam, there is some energy that will go behind and may irritate the nerves. So we are always talking to the patient to make sure that they don't have any nerve involvement. And that's the reason why we do HIFU under sedation. The last is skin burn. Now skin burn, especially in patients with multiple skin incisions, there is a tendency that the scar will absorb the incision. Again, this is another advantage of doing HIFU under sedation, because we're constantly talking to the patient. We're asking the patient whether they feel any pain on the skin. And also the whole HIFU is done with a patient lying in a bowl full of cold water. The temperature is around 14 to 16 degrees. So that will cool down the skin. So the risks of these two are actually very low, and bowel is actually very, very low. It's only 2 in 10,000. Now, the next worry is incomplete ablation. Now, what is incomplete ablation? Now, if I can give you an example, that this is an example of an adenomyosis case that I did recently. This patient has got not a very big adenomyosis, a small adenomyosis, and it's anterior, but she has these big legs. And when you have this kind of big legs, the ablation can be very difficult. And after completing the ablation, I only got very little ablation of this. So this was incomplete ablation because of the disease that the patient had. For how much energy I gave, the adenomyosis didn't die off. And the third risks that ablation involving the endometrium. As I told you all earlier, this is a kind of adenomyosis. This adenomyosis is completely involving the endometrium. This whole wall of the endometrium is involved. Actually, I've got a hysteroscopic finding for this. I forgot to put it up. This is an internal adenomyosis that has involved the endometrium. So when we are ablating this, our aim is actually to avoid this. But sometimes it can be very, very difficult. And you can see when I'm ablating it, it has reached the endometrium here. So this is one of the risks. But whatever it is, I think I've done service to this patient because the endometrium is already involved. And so I'm hoping that this will die off and new endometrium will form and the patient will be able to get pregnant. So these are the risks of HIFU for adenomyosis on patients who want to conceive. So when should HIFU be considered in a patient who wants to conceive? This is the question I always ask when the patient come and see me and they are infertile, they have adenomyosis, should I do HIFU for them? Now, what are the options these patients have? Now, the first option is if the patient have done IVF and have failed several times, and then the IVF specialist send the patient to me, now, can you do something about this adenomyosis? Maybe she's not getting pregnant because of this adenomyosis. Then I will liberally do HIFU for them. Many of my patients are like this. They're sent to me by IVF specialists or my own patients who have not got pregnant after IVF. Then we do HIFU for them. Next patient is a patient, of course, who suffers severe dysmenorrhea and menorrhagia and also want to get conceived. So these patients their pain is so bad, they say, I want to get this treatment to try and reduce the pain and the menorrhagia, and then help them to get pregnant. The third patients are patients with adenomyosis and infertility, but not keen to do IVF. We have this kind of patients. The patients are young, say they are in the early 20s or early 30s. They have adenomyosis, they cannot get pregnant, but they don't want to do IVF. And so they say, okay, can you help to kill this adenomyosis for me? Shrink it, so that a uterus can shrink and the patient can get pregnant. So these are another group of patients whom I do HIFU for them. Now, these are many studies that showed pregnancies after HIFU. The first such study is actually MRI-based HIFU by this person, Rabino Vici, and he had one pregnancy. And then you have Dr. Kim from Korea, who had one pregnancy here. Dr. Loh has 15 pregnancy. Dr. Lee from Korea has 9, but unintended pregnancies. Dr. Zhou, 54 pregnancies, and Dr. Wang has 20 pregnancies. And in all these pregnancies, especially here, there's no uterine rupture during the pregnancy. And many of these patients actually had normal delivery, spontaneous delivery. Here you can see that out of these 20 pregnancies, 11 had normal delivery. So this is one of the advantages. When you do HIFU, instead of doing adenomyomectomy, the patient can attempt to have a normal delivery. So what to do if a patient has both endometrioma and adenomyosis? What are you going to do? This is another dilemma I always have. Now, this patient has got a big adenomyoma, 5 centimeters or 6 centimeters. You also get adenomyosis. Now, which one am I going to do first? So I think it depends on the age of the patient. If the patient is young, and I will probably deal with the endometrioma first and see whether she can conceive on her own. If the endometriosis is not so bad, but the endometrioma is big, then I will do the surgery and then see whether she can conceive on her own. If she cannot conceive, then we can consider IVF. And then if the IVF fails, then we do HIFU. Or we can even do HIFU after the endometrioma. So I'll have a long discussion with the patient to see why she's not getting pregnant. Is it because of the endometrioma, or is it because of the adenomyosis, or is it because of both? And then we will decide which to do first. If the patient is older, say late 30s and early 40s, then I actually suggest them to do IVF if the endometrium is not so large, and freeze all the embryos. Then we can consider what to do. We can either do a frozen embryo transfer or do a surgery followed by frozen embryo transfer, or we can consider GnRH followed by a frozen embryo transfer. And if all fails, then do HIFU. So these are something that I will discuss with the patient, which is the best way to do. I'm not saying that we must do HIFU for all our patients, but this is another option for that patient. So another question people ask me is, should you give GnRH analog before HIFU or after HIFU? Our protocol follows Chongqing's protocol, which is we do HIFU and then we give them GnRH for 3 months. And if the patient doesn't want to get pregnant, we'll put in a Mirena for them. If the patient want to get pregnant, then they either go for a frozen embryo transfer or try to get pregnant on their own. In this particular study, they showed that the combination of HIFU and GnRH is more effective than HIFU alone for ablation of diffuse adenomyosis. So moreover, GnRH pre-treatment with HIFU is safe. So the question to ask is, should we give GnRH before we do HIFU? So that is the question. If some of the doctors feel that if the adenomyosis is so large that you are going to do the HIFU is going to take a long time, then shrink it with GnRH analog for 3 months and then do the HIFU. If the adenomyosis is not so big, I usually don't give GnRH. I just go ahead and do the HIFU for the patient. In this book, Focus Ultrasound Surgery, also edited by Dr. Felix Wong, they say that some patients should have GnRH analog before or after HIFU treatment, especially those with large adenomyosis lesion with rich blood supply. It is a good idea to be aware of the challenges of HIFU treatment in large adenomyosis lesion. The GnRH treatment reduces the size and the blood supply of the adenomyosis. In turn, this will reduce the treatment difficulty and improve the effectiveness of the treatment. However, in some patients, experience suggests that GnRH analog before HIFU treatment can allow treatment done effectively. However, a rebound adenomyosis activities after the cessation of GnRH analog and HIFU treatment may lead to early recurrence. So this is very important, because if you give GnRH analog, the uterus shrinks. And then when you do HIFU, we are worried that the recurrence rate of the adenomyosis may be bigger. So in my mind, if the adenomyosis is not big, I think we treat without the GnRH before HIFU rather than give GnRH before the HIFU treatment. So what about unmarried women? with adenomyosis. This is another question. So we are seeing younger and younger patients with adenomyosis. They're not married and they have adenomyosis. They're in severe pain and they have got a lot of bleeding. They get admitted for blood transfusion. Can we do HIFU to prevent the progression of the disease? Now I have got this example, this 23-year-old lady, single. She was told to have fibroids. Her period is irregular 2 times a month and with severe dysmenorrhea and normal flow. She had a laparotomy in 2018 for cyst, but no cyst was seen, only an appendicectomy was done. Examination shows the uterus was 14-week size and there was a large adenomyosis in the posterior wall measuring 4.9 times 6.4 centimeters. The ovaries had small cysts. Then this is how it looked. This is the adenomyosis she had. So we had a long discussion and we thought that this patient will benefit from HIFU. So we did HIFU and this is what we did. We ablated the adenomyotic lesion. As you can see, we always leave a margin, safety margin around, and this is the endometrium. We didn't touch the endometrium. And this was the uterus 3 months after the treatment. The uterus has shrunk, and when we measured the volume, there was a volume reduction of 51%. At the beginning here, the volume was 945 centimeter cube, and here is 239 centimeter cube. So reduction of 51%. My only wish is that this patient the uterus will remain small. So I'm now trying to encourage her to actually put in a Mirena until she gets pregnant, until she gets married, so that this other adenomyosis that we have left behind will not bleed and then cause the adenomyosis to recur. So these are my last few slides. You all must understand that the uterus has got a volume, and the average volume varies in this study from 15 to 56 centimeter cube. In fact, for a lady who is from between 37 to 39 years of age, the median volume is actually about 46 to 80 centimeter cube. I'm saying this because when we do surgery, when we do the HIFU treatment, we tell the patient that we are aiming to reduce the uterus to about this kind of size, 80, maybe 100 cc. So this is the list of patients that I've done in the last 8 months. We have done 82 cases and we are compiling the data. Hopefully in the next 7 or 8 months, I'll be able to come up with a paper to show you all exactly what my experience is on patients with adenomyosis. This adenomyosis, I've got another 81 patients whom I've done fibroid. Now I'll just close the discussion with one case report. This is a 38-year-old lady noted to have adenomyosis before a second pregnancy. Adenomyosis started getting bigger during the pregnancy. She was given generation analog and then Mirena was placed in 2019. It was increasing the last 6 months from 3 centimeter to 5 centimeters. She has some pain in the legs and also on the right side. Her periods is prolonged and she's gaining a lot of weight with the Mirena. So this is how it looked. This is the uterus before HIFU. This contrast MRI, HIFU, contrast MRI. Pre-HIFU, the volume was 287. And then this is post-HIFU. This is ablation done. And post-HIFU, the ablation, the volume was 133 in 3 months. So reduction was about 53%. And I'm now seeing all my patients back. My first patient is about 8 months. One thing I realized is that after giving what you call as generation analog, the reduction is actually very good. It comes down, but after they get their periods, it rebounds. It becomes a bit larger. So because what happens is the generation analog as well as the HIFU brings down the uterus to a very low time. But once the patient is bleeding, the uterus is filled with blood and so the size becomes bigger. And then I think it will become smaller after that. So this is my experience now. So in conclusion, adenomyosis is a very difficult problem. It is more difficult, especially when a patient wants to conceive. HIFU can be used in both patients who want to conceive and those who want just relief of symptoms. Studies have shown that success rate in reducing menorrhagia and dysmenorrhea is up to 85%. I will be able to give my success rate in maybe another 6 months' time. And not all adenomyosis cases are the same. Some ablation are easy and others are difficult. As opposed to fibroid. Fibroid generally, if they are avascular fibroids, they are generally quite easy. And HIFU is a good option for patients who want to retain their uterus. Thank you. I don't know whether I went overboard or not. Back to you, Ampan.
Thank you so much, Selva. So maybe we have 10 minutes or 15 minutes to discussion and also answer the question. But sorry, now is no question from our audience. Maybe let me ask you some questions. Where is Olalik? Maybe we can come to Joy and discuss together. Olalik,
I'm here,
maybe
ครับ
you also have a lot of questions to Selva. So the first one is, I think in the case that have a abnormal uterine beating, like you mentioned, also Oleg mentioned. So the problem we also heard many times that how you can rule out the malignancy or sarcoma, also endometrial cancer. So that means in case that you have abnormal uterine bleeding, actually you should prove endometrial cancer by endometrial sampling or fractional curettage, and also how about the mass of uterine mass that you quite sure that is not a cancer. Like the last case you mentioned, it is, I think it's 6 months or something, and it increased inside 50%. Is maybe is quite is a point of discussion also. How about your opinion?
Okay. I think what you want to know is what is the possibility that the patient may have cancer when we are doing HIFU?
Abnormal uterine bleeding. I
Yes.
think we should prove before or not, like under endometrial sampling or fractional curettage, and in case that myometrial mass like a fibroid adenoma, how you make sure that it's not cancer?
Yes, you're perfectly right. In fact, when we assess a patient for HIFU, we want to exclude malignancy. Endometrium is one, and the other one, we want to make sure that the mass, which is the fibroid, whether it could be a leiomyosarcoma. That is very difficult. Now, endometrial cancer is easy. We can do hysteroscopy, we can do endometrial sampling, we can do hysteroscopy and DDNC. And in fact, one patient, that's exactly what happened. The patient was referred to me for HIFU, and she's actually a doctor some more. And we looked at the MRI and we didn't like it. We saw that the endometrium is quite thick, and also ultrasound showed endometrium. So we took her for DDNC, and it turned out that she actually has endometrial cancer. And then we had to take her for surgery. So the as far as leiomyosarcoma, that is very difficult. Now, we do MRI, and MRI leiomyosarcoma has got certain features because we also put contrast, and with that we try to look for evidence whether it could be an leiomyosarcoma or not. If there's any suspicion, then we will do surgery. We won't do HIFU. But this is one question that I also asked Professor Zhang Lian when I first was introduced to HIFU. What happened if inevidently, say the patient actually has leiomyosarcoma and we do HIFU? What will happen? I think in my mind, nothing will happen. What will probably happen is that the fibroid will not shrink, and the fibroid will remain, or even in fact start growing. Then we know that it's actually a leiomyosarcoma, and then you go and do surgery. Because the energy is given within the fibroid, I don't think it's going to affect the prognosis of the patient, because the ablation is done within the uterus. So that's in my mind, but I don't think anybody can give you an answer on that. But that's why we follow the patients up to see whether the fibroid is shrinking. If it keeps shrinking, then it's very unlikely that it could be leiomyosarcoma.
Okay.
Professor Selva, I have a question. So can you hear me?
Yeah, I can hear you.
So do you have the experience, the surgery after the HIFU? Because sometimes we know that after we do the HIFU for fibroid, but it's not effect. So we do the surgery?
Yes. I mean, in my series of 163, I still haven't done what do you call as surgery for my patient because I'm still following up, still very early. But I have had the experience of operating on one patient who had HIFU done in a different country about 2 years ago. She had adenomyosis. She wanted to get pregnant, and because we haven't started HIFU, so she went to a different country to do HIFU. And after that, after 1.5, she was well. After the HIFU, she was well. Bleeding reduced, her pain reduced, but later the pain came back. So I actually got to go in and do a laparoscopic hysterectomy. It was a very bad adenomyosis case. So as I said, adenomyosis actually can be quite difficult, especially in patients who want to get pregnant. And in my mind, what I think is that if the patient wants to get pregnant and we do HIFU, they must try to get pregnant as quickly as possible after the treatment. They cannot just sit around and wait for years because it's going to come back. So I like patients who actually don't want to get pregnant because we can put Mirena and then we can at least have some success rate. Our aim is actually not to remove uterus in young patients. If they want to remove later in life, fine. If we can delay the hysterectomy by 5 years, 6 years is good for them, you see. So that is basically the concept. But when they come to get pregnant, in my mind now that I'm doing it for the last 8 months, I think after the GnRH wears off, they have to either get pregnant on their own or by IVF as quickly as possible, because I think whatever we have left behind has got a possibility of coming back in the future.
I have one more question. How about your life after you have a HIFU? because we know that when you do the HIFU, maybe it take a longer time than operation, right?
Yes.
How about your neck? How about your finger?
Yes. I will tell you this. Before HIFU, I was doing a lot of laparoscopic surgeries, and I have the same problems. Rotator cuff, my shoulder is now giving me problem. My legs are cramping up. HIFU, I sit down and do. But it takes longer. You're right, it takes longer. A laparoscopic myomectomy for a 4 or 5 centimeter fibroid, I can probably do it in 1 hour, maybe 1 hour, 15 minutes. HIFU can take up to 2 hours, sometimes even 3 hours, sometimes vascular fibroid. And I have got this pain in the neck because when we are looking at the screen all the time, we are concentrating. I have got shoulder pain and neck pain. So these are things that I'm learning. And I've spoke to my spine surgeon. He said, keep exercising when you're doing the HIFU all the time so that your neck is always supple. And then go swimming, he said, so that your neck will be. So there are advantages and disadvantages. The sense that of course, this is less physically strenuous. Mentally, it is very, very taxing because I'm new. When I started, I started from zero, so I have to concentrate. I have to make sure there's no complication. I make sure I select my patients well. So it's a lot of work. So when you start, it's the same thing. You will have a lot of tension because we are surgeons. Laparoscopic surgery we have been doing for years. We are good at it. We can do it. This is a completely new field. It is something like starting from scratch, and then you have to learn your way to build up. So it's a lot of tension, a lot of pressure, but I think the benefit is a lot for the patient. Patients are very, very happy, actually. Especially my fibroid patients are very happy. They come, they do it, and then they go off, and the symptoms get less, and they are well. Mm-hmm. So, and adenomyosis also, as long as I can help a certain percentage of patients, I'm quite happy because I don't expect to help 100%. But if I can help those patients who are not getting pregnant to get pregnant, or those patients who don't want to get their uterus removed to keep their uterus and reduce their pain and reduce their bleeding, I'm quite happy. So I think in that way, we are doing service to the patient.
So how about the learning curve? We know that when you do the laparoscopy, it takes a long time for the learning curve. How about HIFU?
It took me 50 cases before I could say that I am actually okay to do it. It took me 75 cases before I was doing it by myself. So it is not as simple as you think. You may be able to pick up laparoscopy faster than HIFU. The reason is because there's a lot to learn in HIFU because you need to know a lot of things. And I had a doctor from China who came down, Dr. Huang came down and sat with me for 3 months, and I made sure we have enough cases. So, and I did, I think almost 60 cases with her. The first 50 cases, she was sitting next to me and I was doing with her. The next 10, 15 cases, she was remote. She was assisting me remote. Then after that, Chongqing was assisting me in a remote basis. In a remote basis means they're actually watching me doing, and then I'm also talking to them on WeChat, and I ask them advice, and then I'll do. Then they tell me, actually, you're good already, why don't you do yourself? I say, okay, then I start doing. So the last 50 cases, I've been doing it by myself. So it has got a long learning curve. Don't think that you can pick it up so easily, and you have to be diligent because you don't want complication. This is a new treatment. We want to make sure that the complication rate is almost zero. So it will take time. It will take time for you to learn the technology. It's not as easy as you think.
Yeah, I
Okay.
think so. So the one that I saw many MRI that you investigate for your patient actually is need or not to investigation before HIFU.
The one most important investigation for HIFU is MRI. Now,
Should be
the
every
biggest,
like
yes, MRI is a must. The reason why is important is because ultrasound is not very clear. You all know, and we know, especially abdominal ultrasound. We all know transvaginal ultrasound is very clear, but abdominal ultrasound is always not clear. So you will have your MRI next to you, and you will correlate the MRI with the ultrasound. So the MRI and the ultrasound, you correlate, you measure, you know where your sometimes it's so blur where the fibroid margins are. So the MRI is very important. So MRI is there in front of me all the time, and I know exactly where I'm shooting because I can see the MRI in that particular level. So MRI is a must. No MRI, you can't do HIFU.
Yeah,
Then you have other tests. We have some blood, some tests that we do, but that is the most important test and the most expensive test before you do HIFU. For laparoscopic surgery, I also don't do MRI for my surgery case. I just carry on and do the surgery, you know. So it's not even in multiple fibroids, we just go and look for it. And maybe during the operation, we do ultrasound to look for the missing fibroid. But here you need the MRI.
So because everyone think that we need an MRI to distinguish or to see maybe much better than ultrasound. So someone is just wonder that the MRI guide HIFU is maybe can describe or can see might be much better than ultrasound guide HIFU. What do you think? Because you didn't mention about the advantage or disadvantage between the MRI and ultrasound guide about this part.
Yeah, that is true. There are actually two things. The first is that I have never had the chance to go and actually sit and watch an MRI-based HIFU. I'm not just listening to other people. In fact, I wanted to do that because I cannot tell bad about something that I have not done. It's not fair, you know. But MRI-based HIFU has been in my country for the last 15 years. And the hospital that is doing it is the university hospital. They only done, I think, 40 or 50 cases in the last 15 years. Now, why is it so few cases? There must be some problems. I think the main problem is because MRI, although the clarity is very, very clear to see MRI, there is no live imaging. You cannot shoot and do the MRI at the same time. That is the biggest problem with MRI, I think, because when you're shooting the beam, the MRI is not on. You only do it after. Whereas in ultrasound-based HIFU, we are looking at the uterus while it's shooting. The patient just cough, your focal point moves, and it's so dangerous. It can be in the bowel already. So because of that, we can be a little bit more aggressive when we do MRI-based HIFU. I mean, when we do ultrasound-based HIFU, I can put the focal point very close to the endometrium or very close to the serosa because I'm holding it. If the patient moves, I can stop immediately. You cannot do that in MRI. MRI, you need a very safe margin. Say if you might want to be 20 or maybe 30 centimeter from an important structure, and then put your focal point there, and then you start shooting, and then you 20 to 30 seconds, you don't know what's happening inside. They have got something called temperature mapping. So that is a disadvantage. That's the reason why MRI-based HIFU never did well. I'm sure it didn't do well in Thailand as well. It's available, but nobody sells. The second reason is that MRI-based HIFU is done by a radiologist. Doctors, gynecologists never want to send their patient to a radiologist to do. You want to keep your patient yourself. So that may be another reason why MRI didn't do well. Whereas here, HIFU, you can do it. You are a gynecologist, you can do it. Ampan, you can do it. Ulrich, you can do it. If you can do ultrasound, you can do the HIFU, so you can keep the patient to yourself. That may be the second reason. So I've got no accessibility to go into the MRI room. The radiologist will not allow me to do. So that may be the second reason. But I mean, after doing for so many months now, I think that most important thing is the power that we can put into the tissue is very high, as well as we can see what we are doing. I think that's the basic average. Of course, we have a very obese lady. You put the ultrasound beam, you can't see anything. It's very, very blurred. Then you have to use your MRI to help you to guide. But in thin patients, you can see everything very clear. The MRI is still there to guide you.
So I think maybe we have a few, one or two questions. The time is maybe over. So the one is, you didn't mention about the contraindication, but you mentioned a little bit about the adhesion or scar or something. So that means in case that previous surgery, very common like a section, is a contraindication or not?
No, I didn't actually talk about contraindication. But today I was talking about adenomyosis and not HIFU. There are several contraindications when you do HIFU. The first contraindication is that the fibroid must be not so vascular if you're doing fibroid. So that's the reason why we do MRI, we do contrast MRI. If the contrast MRI shows that the fibroid is full of blood, then the HIFU will not work, because the energy, when you put inside, the blood will take away the energy. So that is one contraindication. It's another reason why we do MRI. We want to see whether the fibroid is a vascular fibroid or a non-vascular fibroid. So that is for fibroids. The second contraindication is, of course, if there is different surgery. A cesarean section is not a problem, because cesarean section is very unlikely that you have anything attached to the uterus. If you have previous myomectomy, if you have previous adenomyomectomy or severe endometriosis, then we are looking for any adhesions of the bowel to the uterus at the area where we are going to shoot. But generally, it is not. Most of the time, there's no adhesions. Another problem is when they have many scars. If they have a lot of scars in the abdomen, firstly, the ultrasound beam will not show your lesion well. Secondly, you must be very careful that the energy will be absorbed by the skin and cause skin burn. So you've got to be more careful. You've got to do it slowly and more carefully. It's not a contraindication, but it is something that we need to be careful about. And another contraindication is, of course, if the patient cannot lie down for a long time. When we do HIFU, before that, we test them, we put them on the machine and see that we are going to lie like this for 2 hours. Are you okay or not? Although they're under sedation, they still must be okay. They must be cooperative with you. They say they can't lie down, then we can't do. So these are some of the contraindications to do HIFU. But generally, most of the time, we can do HIFU. Sometimes I reject patients. So for example, the uterus is too big. We had one lady recently we did. She has a 30 centimeter fibroid. It was right up to the sternum. And I said, I don't want to do this. She doesn't want to do surgery. She's been keeping it for years. She's 42 years old. She's single. She's keeping it for years. She's a sub-serous fibroid, so she's got no symptoms, so she's happy. But ultimately, she said, I want HIFU. There's no other choice. So after discussing with Chongqing, we decided to do her. And we did only half. We said we only do the lower half first. So we do the lower half first and let the uterus shrink, and then we do the other half, because doing on the upper half is very dangerous. It is very close to the nerve. You may have nerve injury. So these are options. So I think not all patients, but some patients are pedunculated fibroid we can't do. Pedunculated fibroid, the reason is if you do, it breaks off, it can go into the skin. In fact, just now I did one lady with a pedunculated fibroid that we didn't want to do because it's too dangerous. Sub-serous fibroids, very large sub-serous fibroid, it will take a long time to absorb because there's no blood surrounding the fibroid. So you can do, but you must explain to the patient it will take maybe 2 years to come down, slowly shrink. The best are the intramural fibroids, maybe 6, 7, 8 centimeters, or multiple fibroids. So these are some of the things, some of the contraindications. So, but generally the contraindications are much less than if you go for MRI. MRI, the contraindications are even greater because of the safety margin.
Okay, I think we have 2 questions from the audience. I think the last 2 questions. How many bowel injury and nerve injury in HIFU? I think from your series you have no light, but from the series.
Yeah, there is one study, one big study. That big study shows that the bowel injury is only 2 per 100,000. Per 10,000, sorry, 2 per 10,000. Nerve injury, I cannot give you the figure, but it's also very, very low. It is probably less than 1%, 0.1%. Mild nerve injury is possible. because those are transient ones, but the permanent ones are the one we are worried about. So it is actually very, very low, and we know which patients will have a higher chance of nerve injury. The uterus is very large. If the fibroids are on the lateral side, on the left side and the right side, those fibroids are very dangerous because those are the places where the sciatic nerves are. So when you ablate, then it can get affected. So I have got a slide that tells all the complications, but offhand I cannot tell you, but it's less than 1% the nerve injury.
So the last question is how cost of the HIFU. I think everyone like to know.
I'm not allowed to say. I'm not allowed to say what is the cost of the machine, but the machine is very, very expensive, especially when you buy it overseas. It's very expensive. It is comparable to a MRI-based HIFU. If you know the cost of an MRI-based HIFU, then it's about that kind of price. The advantage is that the backup is very good. The company that's selling it have got very good backup. They will teach you until. So when you're buying, you're not only buying the machine, but you're buying their service, the what they call the teaching, the module, all that. You can contact them, you can call them anytime. So that is why it is very, very expensive.
So
cost, you can ask Colare to call. I'm not allowed to say the cost.
Me too. I'm not allowed to. I'm not allowed to.
How much the patient that pay average for the one?
In my country, the cost to the patient is about 25 to 30,000 ringgit. That is about about 6,000 USD to about 8,000 USD, around that kind of figure. About 7,500 USD. That's a Malaysian cost. Of course, in other countries it may cost more. Singapore, it costs 3 times more, I think, and in Hong Kong also it costs 3 times more. I think the cost is not the cost of the machine. The machine cost is the same wherever you go. It's the doctor's fees and the rental and all those things. In Malaysia, it's a little bit cheaper because our doctor's fees is actually very, very low in Malaysia. So we could do it with that kind of figure. I don't know. I know there is a machine in Thailand. I think your charges are about the same as us, or maybe even slightly lower, I think, in Thailand.
Okay, I think the time is already over, maybe more than 10 minutes. So thank you so much, Selva, and also Dr. Oralik, for your great dedication and contribution to THGE and also TGMed monthly webinar. Thank you so much. I think everyone happy to join and more understand about the HIFU. And maybe we can have more webinar about HIFU and get more knowledge. Maybe from your series, maybe more than a lot of people that join, and you can get more about the income or the outcome of your treatment. Okay. So I think this time is already over. I have to thank you everyone to join, and also HIFU from China, that for our good partner and sponsor from this webinar. So last but not at least, I'd like to invite all of you to join the TGMed International Hybrid Cardiac Workshop 2022. Now, so we start on Wednesday 23rd to 25th, but for the webinar and allow for our international or overseas participants to join via the Zoom is the 23rd and 24th. And 25th is for the cardiac workshop for our domestic patient because of for the COVID-19 pandemic. So we just keep only Thai people. So invite you guys to join on 23rd and 24th. So the topic is actually we have live surgery every year, but now we invite our speaker to join with 2 hours of every key, like our magnetic speaker every 3 hours period. So they will give us about the theory, maybe half hours, and also 1.5 hours they will show us a long edit video. And we will discuss it, look like a live surgery. So I think everyone to join, we will to see a long edit video from our guest speaker like Alalam, Masaki Ando, and also Harudov in the back. And furthermore, we have a short, like a 1 hour speaker also. So hope everyone can join and also can registration through our website or from QR code that show now. So and also we got another next webinar in the next month, but now we still not plan for all of you, but we will show you later. Okay, on 27, I think it's about GNH analogs or maybe from Dinoges or something like that. It's a medication for treatment of endometriosis. So and it will be Thai version. So our TGMED webinar and also international workshop now will be English version in 23rd and 24th. So kindly invite you to join. So I think the time is already limited. Thank again everyone, Olalik and also Selva and every participant that to join. Thank you so much.
สวัสดีครับขอบคุณครับอาจารย์สวัสดีครับ
Okay, bye bye.
Bye.
Bye. ไม่ทันเหรอ สไลด์ไม่ทันเหรอ